Good day. We welcome everybody to a new webinar hosted by the Hilmi Group, a group who is committed to delivering to the healthcare community from a multidisciplinary perspective, education, research, and extension oriented towards the improvement of health processes and services. Today, we have an exceptional lineup of speakers. We will start first with a presentation by Professor Diego Tlapa from the Faculty of Engineering, Architecture, and Design at the University of Baja California, Mexico, who will present a research he led with the group entitled Lean Healthcare Interventions Supported by Digital Technologies. We will continue with Dr. Luis Enberg, head of the Emergency Department at Hospital Clínico UC, Red de Salud UC-CHRISTUS, Chile, who will present a study on the patient journey in an ER. We will close the webinar with a roundtable along with Dr. Jose Rodriguez, Chief Medical Officer of Hospital Clínico UC-CHRISTUS, Chile, who will present the study, who will discuss the challenges of implementing lean healthcare. We invite everybody to send their questions in the chat of the webinar, which we will address at the roundtable. Without any delay, let me present everybody here and welcome. We will start first with Professor Diego Tlapa with his presentation of lean healthcare interventions supported by digital technologies. Please, Diego, go ahead. Thank you, everybody, and welcome.
Thank you so much, Alejandro. And it's a pleasure to be here. Let me share my screen. So thank you. Hello. For me, it's a pleasure to have the opportunity to present the results of our research entitled Lean Healthcare Interventions Supported by Digital Technologies. The agenda for the presentation will be as follows: introduction and context, research questions, method, results, discussion, challenges and conclusion, and finally, a Q&A session. In today's global context, the healthcare sector faces constant and increasing challenges, including, among many others, the improvement of healthcare quality and efficiency. Internal inefficiencies such as poor patient flow and inadequate utilization of resources may contribute to overcrowding and delays in care. These, in turn, affect patient safety, patient satisfaction, staff satisfaction, and the overall quality of care. The term lean originates from the Toyota production system, which is a Japanese system aiming to increase process efficiency by reducing or eliminating non-value activities. Due to the proven success, lean has been also implemented in many different sectors, reaching the medical domain in the early 21st century, commonly known as lean healthcare. Thus, lean has been a recurrent intervention for increasing efficiency by reducing non-value-added activities from healthcare services. In fact, in the US alone, a national survey found that around 70% of hospitals use lean or related approaches. In addition to lean, Six Sigma is a methodology focused on reducing variation in process or services, which is frequently used with lean to improve processes. Improving efficiency and quality of care can be further enhanced by applying digital technologies offered by the Industry 4.0. Healthcare 4.0, as it is also known, adapts applications and principles from IO 4.0 to healthcare settings, allowing traceability, real-time visibility, and care customization to professionals and patients. From replacing dry boards with computerized patient tracking system in emergency departments to replacing human observers with wireless tags for determining the location of patient and staff, this is how digital technologies benefit the healthcare services. Digital technologies are varied. In recent years, there has been an increasing number of interventions in healthcare, including telemedicine, machine learning, big data, automation, simulation, wireless medical devices, robot systems, electronic tracking systems, sensors, and many others. Lean and DTs have been studied mainly in manufacturing companies. Studies in healthcare are scarce. Research on the effect of such interventions remain in the early stages. This provides an avenue for raising the following research questions. The first question is, which digital technologies support lean healthcare interventions? Another question is, what are the effects of lean healthcare interventions supported by DTs on healthcare? In order to answer these questions, we conducted a systematic review of lean interventions supported by DTs. This systematic review was conducted according to the PRISMA guidelines and the Cochrane Handbook for Systematic Reviews. The protocol was prepared and registered on Prospero. In order to follow up the progress of lean and DTs interventions, studies published in English up to December 2020 were searched. We use 5 databases and other sources of great literature. In addition, in order to generalize the effect of the interventions, different types of studies were searched, including control before-after, randomized control trials, case control, and pre-post studies. We selected studies carried out in healthcare units applying the intervention to inpatient and outpatient care. The intervention included lean healthcare and digital technologies highlighted on the slide. We compared the results from control groups versus intervention groups, as well as pre-post results. Regarding the outcomes, we searched for studies reporting main outcomes related to patient flow, such as those described as utilization or access to service by the Cochrane APOC group. For example, in utilization of service, length of stay for inpatient and outpatient was measured as the time a patient spends from the admission to discharge. Turnover time, that is the time between the departure of one patient and the arrival of the next one. Turnaround time, the time from completing one procedure or service and the beginning of a subsequent procedure or service. Related to access to service, we search boarding time, measured as the interval elapsed between the admission decision and the assignment of a hospital bed. Waiting time, the time spent waiting for a consultation completed by a health professional, the number of individuals who left without being seen, and finally, the waiting time for an appointment. However, to expand our findings, we also search for studies reporting patient outcomes, quality of care outcomes, patient satisfaction, and staff satisfaction. Let me erase this. The majority of the studies included were observational. Therefore, the risk of bias was assessed by employing Cochrane's tools Robbins I. The results here, the Prisma flowchart shows that the search in the databases yielded 3,750 titles. After removing duplicates, opinion papers, abstracts, 951 studies remained for the screening. Then, 769 studies were removed after applying the criteria for exclusion, leaving 182 possible studies for submitted for eligibility. During the full text review stage, 156 studies were eliminated and only 26 studies were considered in this review. Regarding the types of interventions, 17 studies utilized lean healthcare supported by one or more DTs. The remaining 9 studies reported a combination of Lean and Six Sigma interventions supported by at least one digital technology. In regards to the research scope, all interventions occur in departments or processes, but not in the whole organization. The largest number of interventions occur in EDs, with 10 studies, that is 38%, and followed by laboratories with 5 reported interventions. The leading supportive digital technologies used in the lean interventions were simulation and automation, with 9 studies each, followed by electronic tracking systems, robots, and machine learning. Regarding the effect of lean interventions supported by, for example, simulation, 9 studies reported improvement in 15 out of 16 reported outcomes. Notably, 5 reductions in the length of stay occurred in emergency department, and a similar number were reductions in waiting time. On the contrary, 1 study reported no change in the length of stay for inpatients. Automation was the supportive technology in 9 studies as well, yielding improvement in 15 out of 17 outcomes. Reductions in the turnaround time lead with 9 outcomes, all of them reported in laboratories. 2 outcomes were reported with no change after the intervention as well. In 8 studies, electronic tracking systems were utilized as supportive technology in which improvement were reported in all 12 outcomes. Less frequently used technologies included robotic systems to improve the turnaround time and machine learning to improve the length of stay and the percentage of patients who left without being seen. As a summary of the main effects, the following graphs shows the 5 frequent reported outcomes. First, the turnaround time is the most frequent metric, reporting a reduction in all 17 outcomes after the interventions. Length of stay were decreased in 12 out of 16 outcomes. Conversely, 3 studies report no change after the intervention and only 1 report an increase in the length of stay. Concerning waiting times, 6 studies reported improvement in all 6 outcomes. Regarding turnover time, 2 out of 4 studies reported a reduction. On the contrary, 2 non-significant increases in TOT were reported after the intervention as well. 4 studies measured the percentage of patients left without being seen, each reported reductions. Less reported outcomes after the interventions included 30-day readmission rate, adherence to recommended practices, percentage of on-time starts in the operating room, staff walking distance, nurse lead time, room utilization, with only 1 improved outcome each. However, the 30-day readmission rate had an additional outcome of no change. Only 2 studies evaluated patient satisfaction, each reporting improvement after the intervention. Staff satisfaction was measured in only 1 study, also presenting an improvement. Finally, we did not identify any outcomes related to boarding time, mortality rate, and waiting time for an appointment. Overall, simulation and automation were the main supportive digital technologies in lean healthcare interventions. With regards to simulation, this technology stands out as a powerful decision support technique among the main trends of the Industry 4.0 era. In this review, simulation was used mainly in emergency departments for measuring patient flow outcomes. We also identified 2 approaches to the use of simulation in lean healthcare projects. The first involves a practical intervention using simulation as a means to model different scenarios in a healthcare setting, followed by the adoption of the best solution, while the second involves a theoretical study that combines lean and simulation to propose potential solutions with no reported implementation. Regarding automation, this was used as supportive technology in 9 interventions. Lean automation incorporates digital automation technologies into the operationalization of lean practices. Our analysis found that automation was mainly used to support lean healthcare in laboratories. That also implies that healthcare can benefit from automation where standardized process and routine operations are followed. Although lean interventions are reportedly used in healthcare systems in different contexts, we did not find evidence of lean healthcare interventions supported by technologies such as Internet of Things, big data, virtual and augmented reality, fog, mobile computing, cloud computing, 3D printing, telemedicine, open source software, and blockchain. Thus, few digital technologies have been utilized to support lean healthcare, reflecting a low pervasiveness in different healthcare settings. However, that seems to signal initial approaches to incorporating in a staggered manner extended and more complex types of digital technologies into lean healthcare interventions. Particularly, simulation is considered an intermediate step towards more sophisticated technology such as digital twins, identified as the next modeling, simulation, and optimization paradigm. In such new paradigm, the use of simulation will be extended to support the design and redesign of patient-centered healthcare settings. Although patient satisfaction is perceived as a key element in directing process improvement initiatives in healthcare systems, we found that it is rarely measured and monitored in lean and digital technologies interventions. In fact, we found that only 2 out of 26 studies reported it. Such finding is consistent with previous studies highlighting that most lean interventions tracked the effects on throughputs but disregard patient satisfaction outcomes. However, the finding is also contradictory as patient involvement grows in relevance given the continuous feedback facilitated by the Internet of Things. Another outcome scarcely measured is staff satisfaction. Despite the fact that a growing body of literature outlines the staff fundamental role in healthcare, we only identified one study reporting this metric with good results after the intervention. This is opposite to the highlighted need for analytical attention and technological solutions focused on minimizing the burden experienced by physicians and nurses. Thus, the findings imply that most intervention studies still focus on efficiency improvement in a department rather than taking a holistic perspective to optimize the outcomes across the entire patient journey process. Several countries have adopted strategies to increase healthcare efficiency, including lean. For example, in the United States, less Medicare spending per beneficiary has been linked with lean healthcare interventions. Despite being at the core of lean interventions, outcomes related to savings and earnings were reported in only 2 studies. This lack of cost-related outcomes is consistent with reports of a negative association between lean and financial cost and the inability displayed by hospitals to translate lean benefits into savings. In this regard, the cost reduction analysis possibly related to H4.0 implementation in lean healthcare interventions might be complemented by different investment decisions in such technologies. Lean and digital technologies as a dual intervention entails significant technical and organizational challenges, including the reallocation of personnel and equipment resources. Such reorganization is needed to adapt the technology to social needs, including the beliefs and barriers of patients and caretakers. Moreover, physicians' resistance to change has been commonly reported when implementing lean interventions due to the perception that lean interventions might target established medical practices. However, in the present study, we did not identify any reported resistance to the dual intervention of lean and digital technologies. This could be a future research avenue due to the increasing implementation of these interventions. Regarding technical challenges, IT services and infrastructure present various implementation difficulties, including difficulties with system configuration, system access, software updates, and poor user interfaces. Further difficulties in implementing DTs included a negative impact on staff communication and the level of situational awareness in EDs in the conversion to automated tracking system from manual ones. In addition, the age of ownership of the hospital, type of hospital, number of inpatient beds, and the number of employees have also been reported as contingency factors in adopting Age 4.0 technologies. So this is the end of the presentation. There will be some question and answer session that will be at the end of the presentation. So thank you so much. This is my email for any questions so far, and the complete list of references can be requested by email at this email. Thank you so much.
Thank you very much, Diego, for your presentation. We have some questions from the audience that are coming. Please keep them coming through the chat. We'll address them at the end of the presentation. And now we will continue with the presentation of Dr. Luis Emberg, head of the emergency department at Hospital Clínico UC, who will present the study on the patient journey in IR. Now we will start with his presentations. Thank you very much.
My name is Luis Enberg. I'm an emergency medicine physician and master in health administration. Today, I will talk about how our experience has been improving the patient's journey using the lean methodology. We will talk about the importance to really know your patient, workstation or production unit, patient care process, and the importance of identify the root cause of the problem. I have no conflict of interest, and these are my affiliations. Why is it important to talk about the patient's journey, especially in the emergency department? Every day, the emergency departments around the world are overwhelmed by the large number of patients, and we must be able to absorb this demand. In order to achieve this goal, we must work to build an orderly and error-free service process. All the patients are different. They have different reasons for going to an emergency room, and they also demand fast and error-free care. Orderly process allows us, regardless of the type of patient or disease, to be able to attend the patients in the shortest possible time, maximizing the use of resources. Another problem faced by emergencies and most hospitals in general is that due to the increasing demand, attempts are often made to compete by structurally increasing infrastructure without first establishing the patient's care process. This causes, on some occasions, that the structural development affects the process, increasing its time and waste. In the end, the treatment turns out to be worse than the disease. If there is no clarity in the patient care process, the speed demanded by patients often leads to disorganized workstation, which increases the risk of making mistakes, slows down care, lowers quality, and generates dissatisfaction. The constant arrival and lack of knowledge about the patients, a structure that is not consistent with the process, messy and dirty workstation lead to burnout of health workers, which not only impacts the team, but also the patient and their treatment, creating a poor work environment and an unsuitable place for patient care. Health processes are complex due to their characteristics. Being a service, the product is created when it's consumed. If the building, the work team, or the process are not adequate or are poorly defined, the delivered product will be deficient, increasing the risk of error. Has multiple interactions with service and equipment that do not always depend on the unit. It involves many people who, if they are not clear about the process, can make mistakes or slow down patient care, and requires a high level of knowledge and training to deliver the best care. This often leads to a confrontation between those who deliver and those who analyze the care delivered. By properly analyzing and defining the process, we can speak a common language that allows us all to advance in reducing the waste of the process and deliver the best care to our patients. Every day we must work hard, but we must also work smart, as is done in the resuscitation of a patient. In this type of situation, it's critical that everyone knows the evaluation process, the necessary treatment, and the role of each one within the team. This can only be achieved by knowing who and how we deliver care. For this reason, it's so important to know very well the care process of our patients. How can we achieve this? How do we go from working in an environment that is often chaotic to an environment free of waste? The first thing we must understand is that there is no silver bullet. All institutions are different. The patients they receive are different. The medical facilities and equipment are different. So we must be able to know our local situation and our own performance without trying to copy exactly the same solutions that others have found. As I just said, there is no silver bullet, but there is a methodology that can make our work easier. That's the Lean philosophy. Lean in health allows eliminate waste, shorten cycle time, increase value-added activities, speed up value creation process. Lean is based on 5 key principles: value, value stream, flow, pool, and perfection. But the first thing we must do is know to whom we deliver the service, characterize our patients. In our health network, we have sought to characterize our patients in the most complete way. For this, we have seen its gender, age, level of complexity, what in medicine we call triage, seasonality, weekday, and time of the day. In addition, we frequently carry out satisfaction surveys that allow us to know what they value, what their suggestions are, and what points of the service they find that we should improve. Thanks to this, we know that what the patients value the most is the time spent with the doctor and the clarity with which his diagnosis, the necessary medical test, the cost involved, and the treatment he's going to receive are explained. On the other hand, it does allow us to know that they don't value long waits and lack of information. Second, but no less important, is our work team. The best way to improve the care process is to do it together with them. For this, we must know their concerns and needs. One way to facilitate and promote the interactions of the different members of the work team is through a Kanban board. Patients can even be invited to collaborate with ideas to improve the process. In our Kanban board, we have 4 areas: ideas, to do, doing, and done. Weekly, as a team, it's decided which of the ideas are feasible and important to carry out. In addition, In this way, the team can help to see which tasks are lagging behind and jointly find out what reasons are delaying them. You can also see which proposals were completed, which allows collaborators to see the results of their proposals. It's very important to know in depth what our production unit is. In this way, we will know what resources are involved, the state that they are in, the cost of this, the use that is being given to them, and if it's consistent with what our patients needs. It must be taken into account that the production unit, we call box, will depend on the hospital in which it's located and the resources available. However, analyzing what we have and how we use it will allow us to improve its use. To improve our processes, the first thing we must do is clean up our workstations. A tool that allows us to systematically order our production unit is 5S. 5S came out of Toyota and does not include SAFE. US industry started adding safety as a sixth S due to the importance of workplace safety along with workplace organization. Many organizations are adopting 6S, but many also use 5S. The 6S are used to clean and organize a work area. 6S can help prevent workplace injuries. They can make it easier to cross-train employees by having a place for everything and by having everything in its place. They can improve workforce morale by creating a clean work environment. When a work area is a mess, it's often difficult to determine the status of the work in the area, how value is added in the process, or who is responsible for the work that is done. Implementing 6S is often inexpensive and a first step in a lean journey. It quickly becomes a way of thinking from the frontline employees to the top management. This is an example of the beginning of the application of 5S during the beginning of the pandemic in Chile. Once we know our patients, our team, and our production unit, we must establish how all this is articulated, how we work. The best way to do this is to see it from the patient's point of view, as a strip generates the interaction of the different parts that compose it. Ideally, this analysis should include activities, time, documents, computer systems involved, staff, inputs uses, and attention times. As a simple way to visualize our patient's journey is to draw a spaghetti diagram. The spaghetti diagram is a visual representation of the physical flow of materials, paper, and people through the task or activities of a process. It details the flow, distance, and waiting time of the transportation of it in the process. It also traces the walking pattern of the people, shuttling back and forth of the materials between tasks and workstations. We have applied it in two ways: asking someone to follow the patients or asking the patients to draw their own journey on a service map template. Another way to draw the care process is through a flowchart. A flowchart is a picture of the separate steps of a process in sequential order. The way that seems best to us to visualize a process is the value stream map. The term value stream map refers to a graphic representation of the trail of activities that occur from the moment a request is made for a service or product until the moment that the request is satisfied. Value stream map offers a high-level view of the steps and activities in a process and allows you to recognize where there are areas of concern and opportunity on which you can focus your problem-solving resources. Value stream maps are a fundamental component of the Toyota production system, the lean philosophy that allows you to deeply understand processes so that work can be adjustable to increase value to the customer, eliminate waste, and reach the ideal state. In this image, I show how we use the value stream mapping to evaluate the process of care for low complexity patients, who are the patients who most frequently visit the emergency room. This allows us to identify the point of improvement and realize the large number of different resources involved. Using value stream mapping allows us to visualize the ways or mudas of our process. The 7 mudas for the healthcare are confusion, motions, waiting, overprocessing, inventory, defects, and overproduction. Recognizing source of muda in daily works is the first step in eliminating waste, and eliminating waste is the first step in recognizing the value in a worker's time well spent. When healthcare workers look at their work with a keener eye for mission value, the healthcare environment transforms to a safer, more affordable network for healthcare management. When an error is found, the immediate reaction should still include fixing the problem in the short term. When errors occur, the lean approach prompts us to not ask who. Asking ourselves why leads us to the solution of systemic root cause problem. A root cause is an underlying condition or aspect of the system that led to the error. If an issue that we've fixed recurs, it's a sign that we haven't discovered or fixed the root cause. We can use 2 ways to identify the root cause: the Ichikawa diagram or the 5 because. An Ichikawa diagram is a diagram that shows the causes of an event, but we prefer the 5 whys, because one powerful yet simple method for getting to root cause of a problem is the 5 whys method, developed at Toyota. In this method, we ask a sequential series of why questions until we get an answer that seems like a correctable root cause. There is no particular magic in the number 5. Sometimes the root cause is found after 3 whys, and sometimes it might take 10. The point is to get beyond more commonplace problem solving that might only ask why once, leading to a surface symptom instead of the root cause. This has been the beginning of our lean patient journey. This has allowed us to realize that to improve the care process of a patient, we must characterize and categorize the patients, know and order our workstation, define and communicate our patient care process, and find the root cause of the problem. Thank you very much for your attention, and here is my email in case anyone needs more information about the lean patient journey in our institution.
Thank you very much, Dr. Emberg. Great presentation. We will now start with our roundtable, in which we graciously have with us Dr. Jose Rodriguez, who is the Chief Medical Officer of Hospital Clínico UC-CHRISTUS. And first, we will start with Dr. Jose Rodriguez. And please introduce us, because most of our people here don't know the sites, the problems you face in the Hospital Clínico, the Universidad Católica as a teaching hospital. And if you can share with us the management challenges you have faced as a medical director of a large teaching hospital. Thank you very much, Dr. Rodriguez, for being with us.
Hi, good evening, everybody. I'm very pleased to be here with you. Thank you for your invitation. It's a great honor for me. But first of all, I have also my own disclosures. And I have to say that I don't have any belt on lean management. Obviously, I've been familiarized with the main characteristics of this management philosophy. A little bit about myself. I'm a pediatrician. I worked for a long time on pediatric critical care, and perhaps I can say out of the blue, because of some special situations, I got involved in management. So I was appointed as the chief of pediatric services, and I was enchanted with that, with this role. Then I went into a Master of Health Services program into University of Missouri, and I came back to our hospital in 2010, and I was appointed as a medical subdirector. And in 10 years later, I went into my current position as a medical director. And I have to go back to 2010 when I assumed it in my role with Dr. Rabagliati, who was the medical director back then. Our main purpose, and until today, was to struggle with something that you probably, especially physicians in the audience, should have heard about it. And it was the silo structure of a hospital. That was our main struggle, and probably I'm proud to say it. We have been quite successful in that job. That was very rewarding for us, and of course for our institution, and finally to our patients. That was our main challenge, to work on this issue, which is a huge, I'm using lean jargon right now, it's a huge source of waste, the silo structure of the hospital. Perhaps we can work on that idea. I don't know if...
Absolutely. Please go ahead and tell us how you devise ways to destroy this silo structure inside the hospital, because generally everybody works on his area and doesn't care about the other physician's area. You just go and do your stuff and forget about the rest. How did you work that out and integrate the different parts that do not talk together?
Well, it was very exciting. At the beginning, it was for a long time before, but we realized that in 2010 that our hospital, back then it had about 500 beds, 25,000 discharges a year, and an average length of stay of 4.6 days back then, with an occupancy rate of about 77%. 15,000 procedures a year. And every morning we come here and we just do our job. We didn't have any idea how many beds do we have available for the daily demand. And when time got hard, we just received messages. We don't have beds for for today. We have a lot of surgeries. What can we do? Well, and we started doing a very short meeting every morning, figuring out how many beds do we have, free beds do we have that morning. Then after that, it was not enough. We need to know how many procedures was programmed for that day. Then we got the information from the ED. How many patients do you have in boarding? And that initiative started growing and growing. We realized that with the classical structure of surgical beds and medical beds, we have a lot of inefficiencies. Because, as in the old time, a group of beds was practically the property of a surgical specialty. We couldn't touch it because those beds belonged to surgeon A, those groups to surgeon B, and we couldn't use it to satisfy the daily demand. So we went to a model of SurgMed beds, respecting some kind of beds, especially the hem-onc beds, which was very, very specific about the how can I say it? They need some special conditions and capacities from the human resources that was enough to keep them as a special areas, and of course of the pediatric areas and neonatal areas, because our hospital is a general hospital. I forgot to say. So we went much efficient in the use of beds. After that, we developed a sort of forecasting every day. We work a lot with the engineering, with our engineers developing some computer models about the ED demand. Luis wasn't here, right? but I worked with some people related with him. So we started to, with this forecast, we knew with a 10% of dispersion how many patients are going to be received at the ED and admitted. We knew how many surgeries were programmed. We knew how many referrals we were going to receive. And we got a pretty good forecast about the daily activities. And after that, we realized that we needed to join the pieces. And we created a unit. We are very creative here. The unit was called C3, and it means Central Command of Beds. Beds in Spanish, we say cama, so that was the third C. And we have now the C3 unit. And what do we do with that unit? It's exactly as a control tower of in an airport. They manage all the referrals. They work, and that was a nice job. They work on the early discharges. before that unit, no more than 20% of the discharges concreted before or went effective before noon. Today, about 45-50% of our discharges are went before noon. That was a very big. We're very proud of that. It was interesting because many people say, why don't we go to 100%? That's nice, but that's impossible. It's like to ask to go at the to ask a car to ride at the light or at the sound speed. That's not possible. We can talk about it. It's very interesting. So early discharges, case managing, forecast, and bed assignment. We concentrated all of these issues on the C3 unit, and it really changed our operation. For example, in 2010, we, as I told you, we had 500 beds. Today we have only, we went down to 420 beds. That's because we improved our the quality of our rooms. In the past, we have shared rooms. We are going to single or at least double rooms. But we are managing the same bed days as in the past. And we are doing also more surgeries. Of course, our occupancy rate rose to 85-90%, but we are managing that with this approach. I think I talked enough.
No, great. This is great because we're observing now a process view of everything. You destroyed the silos and you perform a process view of the system. So you integrated things that were not integrated and coordinated everything. So congratulations.
Yeah. Oh, thank you. Of course, we have a lot of resistance because we are breaking a cultural issue. That was very tough.
Yeah,
I think the
most important thing about the C3 and that model is allow us to do more with less. It's very important, and do more with less is one of the most important parts of the lean philosophy. So we are trying really hard to apply some things from lean philosophy, but it's hard because you have a cultural problem, especially in the medical team, because we are like cats. Nobody could move us, so it's a little bit hard sometimes. But we are trying hard to change some things, and I think the C3 experiences are very important, and it's a very important change in our hospital.
I will get back into that part of you being cats, but we'll take some questions from the audience now. There's a question for Dr. Diego Tlapa. What are the unintended consequences of focusing on outcome measures linked to efficiency, such as length of stay? Turnaround time, as indicated, is most of the lean healthcare study. You're muted.
Thank you. Yes, indeed. Mainly lean healthcare focus on efficiency metrics, and that might be the reason why medical staff don't get the attention from this kind of metrics. So those kind of metrics, efficiency metrics, are closely related to management of hospitals. An unintended consequence might be not getting a proper support from medical staff and even patients, right? So that might be one of the important things here. So the challenge here is to gain greater involvement from doctors, and I am excited to hear from Dr. Luis and Dr. Jose Rodriguez the level of involvement in such kind of interventions, right? So, in my opinion, from the results from this review, mainly lean at the first stage might be said is focused on efficiency, but there are more and more interventions focusing on patient outcomes and quality of care outcomes. So that might be maybe a second or third phase in this kind of involvement.
Thank you very much. We have another question. Do we need to rethink the measures that we use for lean healthcare research? Most of the outcomes measures does not align with the first lean principle of creating value from the patient's perspective.
Yes, that's correct. Well, basically here, there are many outcomes there. There is a group named the EPOC, the Cochrane Effective Practice and Organization of Care Group, and they propose several outcomes related to patient outcomes. For example, health status and well-being, quality of care, utilization of care of services, access to services, and many others. So the outcomes are there, and also they are asking for more kind of intervention. So maybe the focus of the interventions might expand to include those kind of outcomes as well.
Thank you very much. We'll now continue with Dr. Emberg. This is for you. Lean relies strongly on process standardization. Standards are certainly reviewed and improved throughout Kaizen initiatives. It is well known that physicians are resistant to follow standards in the care of clinical operations. How do you balance this conflict of implementing lean in hospital services?
That is true. It's difficult to. It's difficult. Try to put manufacturing philosophy in the health system, because it's if you could think that it's a different. It's a different area between the manufacturer system and the health system. But if you look at patients, you could see people who really want a good service, and the best practices in good service are in the manufacturer area. So you must try to talk, and you must try to explain to your team the importance that thing, because sometimes if you only show what are you doing for a lot of years, you always will have the same results. So if you want to do some change, it's important take some experience from the other areas. And every day I try to talk with our team, and I try to say, it's important if you follow the patient. It's important if you talk with the patient, and it's important that because it's your client. The best practices in that area are in the manufacturer area, and the important in health, we have the result that is very important for us, especially when we talk about a disease and the treatment for that disease. But now it's more important the journey. If you offer a patient a good result but a bad journey, the patient said, "You are not giving me what I want." So every day I try to talk with the doctors in the emergency department, and we talk a lot about with Dr. Rodriguez, and we are trying to develop some tools and to develop some things to give the possibility to explain the doctor that. But it's really hard. It's not easy because we are like a cat. So I don't know. I don't know what the experience Dr. Rodriguez could tell us about the experience of that.
Excellent. Well, go ahead, Dr. Rodriguez.
Okay. Thank you, Luis.
It's hard. It's really hard.
Yeah. Well, you know what? Some comments. This job is like a hospital budget. A hospital budget includes probably 65 or 70% of the budget in persons, people. In my kind of work, you have to do the same. Second, a long time ago, somebody told me that, not a long time ago, it was about 10 years ago, that in this kind of job, the shortest way between 2 points is not a straight line. And it's absolutely true. You have to, in general, people in hospitals, they do really a great job. You have to understand that. If they do their jobs in this way, it is just because people in charge hasn't provided a better scenario for them. So you have to understand that, get involved with their jobs, and talk with them, understand them. Why do they do the job in that way, and explain them in different ways that there is an easy way to do it, not a better way to do it, an easy way to do it. There is a lot of issues that at a first glance you can think these people, they don't understand it, but that particular way to do their job, it is because they discovered that they need it, and you have to take care of that. You cannot say to them, this is a very wrong way to do it. It has a reason, but you have to create the conditions for them to understand that there is an easy way to do it. I always say to them, I think that I told it to Luis also, that my job is to allow them to do their job in a better way, in an easier way. I mean that's the approach to the right approach to work together with them.
This is sounding like the TV series, the one of the hospital where "May I be of your help." They thought of you when they did it. We have another question for Manish. For you, Dr. Rodriguez. Have you seen a shift in the culture where the nurses have voice or power to remind senior staff if they have missed to follow standard operating procedures or commit an error? You have seen a change in the culture of the nursing staff?
Excuse me, say it again, please.
If you have seen a change or a shift in the culture where the nursing staff talks to the medical staff and tells him, "Hey, remember there are standard operating procedures. There are, or if you're going to commit an error." From the nurses to because generally hospitals are very vertical organizations: medical staff, nurses, and the supporting staff. And there's generally no interaction upwards. Have you seen shifts in the culture?
Absolutely. And you know what? Long story short, in our country, I guess it's the same in other countries. Historically, it is the same. After Semmelweis, who was ignored by their colleagues, probably the very first person to talk about quality in hospitals was Florence Nightingale. We just celebrated her day just a few days ago, last week. And in our hospital, quality before the accreditation approach for hospitals in our country was in the hands of nurses. And I think it is the same today, but physicians have been absolutely involved in this issue. In the past, they didn't concern about that. But today, really, the nurses are the main support of our quality process. We are now facing our third national accreditation process. It started in 2013 in whole the country. That was a very driver for us to be involved, and it's a main issue here. We measure our report rate of adverse events. That's also a very strong lean concepts. I mean the psychological condition to pull the lever and stop the process. And I think it is very, very unusual for a nurse today, or including another. We have nurses, we have medical technicians, and they have the how can I say it, the scenario to tell about it for everybody. And also regarding that, in our medical bylaws, we are very severe against how can I say it, bad behavior. I mean, I don't know if I'm using the right word. I mean, disruptive attitudes against other members of the medical team. I think we have done a very pretty good improvement in this area. We don't tolerate currently. We don't tolerate disruptive relationship between members of our teams. I mean, that's the key issue, to have a real team with a psychological safety in the environment. But today, nurses and other members, including junior staff, they have the environment to talk about it, to tell people that we are in danger of quality deviation.
Excellent. And I have a tricky question. Generally, we learn more from our failures than from our successes. So if you could tell us, which is your greatest failure as a medical director, and what did you learn from that failure that you would tell everybody, hey, please don't make the same mistake?
Good question.
Yeah, but
it's a very tricky question.
Yeah, tricky.
Yeah, but you know what? I think somebody told me also that we have one mouth and two ears. So you have to hear twice as you talk. And I guess I will commit the same error probably several times, but I mean, it's quite important to hear people, to hear them very convincing deeply, and that's very important to talk with people, but mainly to hear them.
Excellent. And here is a question for the group. And how do you feel like, because here with Diego, Professor Tlapa has talked about technologies supporting lean. Luis has talked about processes that support lean and the patient journey. And Dr. Rodriguez has talked about integrating different stuff. How does technology, patient journey, and integration worked, and how can it be implemented in healthcare systems? It's an open question.
You know, I think it's important first create a culture about improvement. I think before, if you want to apply some device or some technologies in the journey of the patients, first you must know your process, you must know your client, your team, your work team. Because if you only put devices and technology and try to put and you push a lot, sometimes you don't receive and you don't have the results that you want. So I think before everything, before applied technologies, you must know your client, your work team, and your process. I think that is the most important thing if you want to do a culture change of your culture, or if you want to change some things in your hospital. I don't know, what do you think, Diego, about that?
Yes, I completely agree with you, Luis. First of all, these digital technologies are tools to support the health staff, medical staff. However, after prior to involve those kind of technologies, because they are also expensive, we need to have the basis to implement them. So good communication, good relationship among the staff, all the process well established before those kind of involvement of those kind of digital technologies implementation is required, right? So in our countries, right, in Latin American countries, this is maybe far away. At least I'm speaking by Mexico. Those kind of digital technologies are not well implemented yet because we don't have the basis as in other countries. So maybe you have also the same situation, I don't know, in Chile. But first, the general condition for public and private hospital in Mexico are not as we desired for them.
Thank you. Okay, I think with that, I want to give a very huge round of applause to our speakers. Thank you very much for everybody. We would like to thank Professor Diego Tlapa, Dr. Luis Semberg, and Dr. Jose Rodriguez for their presentations and sharing experience with us. We hope this webinar was insightful for you, and we invite you to see our work in the website www.hilmigroup.org and to join us in a future webinar. Stay safe, and we'll see you. Thank you. Thank you very much for our audience.
Thank you. See you then.
Thank you.
Bye-bye.
Bye.